Okay, everybody. So I have received a lot of queries regarding how to solve MCQs. So student usually comes to me and says that sir topic तो अच्छे से पढ़ ली है and we are well versed with the topic. Still, when it comes to solving MCQ, we are not able to reach up to the correct option. So in view of that, I have decided to launch this video which is having 10 MCQs, which is the collection of your previous year questions, both NEET PG and FMG. And based on the discussion that we are going to do on these 10 MCQs, my major idea will be to make you reach towards the correct answer. And there are two methods of reaching up to a correct answer. One is by simply looking out for the answer in the 4 options which are given. Second is to eliminate the option one by one. So I would suggest all of you to follow the second method. Always try to eliminate options one by one. By that, there are high chances that you are going to get your question correct. Yes. And as I always say, even one MCQ has the ability to shift your party destination from Malaysia to Mahabaleshwar. That is so much of competition involved in your PG entrance competitive exams. Yes. So with this, let's do first question. So the examiner has simply asked you to identify the image. So this is the X-ray image. Now, if you compare both the sides, so you can see that here there is something which is dropping down the orbit. Now what is this? So this is your teardrop sign. Now teardrop sign is when there is blunt trauma to the orbit, it leads to the fracture of the orbital bones. Now the tear is dropping down the inferior wall of the orbit now. So that goes in favor of the fracture of inferior wall of the orbit. So of course, it cannot be a posterior wall. It cannot be a lateral wall. It cannot be a medial wall. But this is inferior wall of the orbit. This is teardrop sign which is seen in X-ray in orbital blowout fracture. The term which is used for blunt trauma of orbit leading to inferior wall fracture is orbital blowout. This is your previous year FMGE question. Yes. So you have to be well versed with the concept. Coming over to the second question. So a person with jaundice. First, let's underline the keywords. So the person is having jaundice and tremors. So tremors, they have not specified which form of tremors, but if we connect the dots, so tremors which are seen in jaundice, in liver disease, they are generally flapping tremors, right? Is showing the following finding in the eye. What is the diagnosis? So boys and girls, this is an integrated question of medicine with that of ophthalmology. Now what is this peripheral greenish golden ring that you see? Now jaundice is there, tremors is there, so that goes in favor of something which is KF ring. KF ring is Kayser-Fleischer ring. Yes, Kayser-Fleischer ring. What is this KF ring? It is the copper deposition at the Descemet's membrane of the cornea. Descemet's membrane. So there are different layers of the cornea from anterior to posterior. There is anterior epithelium, there is Bowman's membrane, there is corneal stroma, then Dua's layer, Descemet's layer, and endothelium. The easiest way to remember is A, B, C, D, and E. Yes. Now don't confuse Kayser-Fleischer ring with that of a Fleischer ring. Fleischer ring is deposition of iron on the corneal epithelium and it is seen at the base of keratoconus. Yes. Now jaundice, tremors, presence of KF ring, and you know KF ring is actually copper deposition. So that actually tells you that this is some disease associated with copper metabolism. Yes, and out of these four, so heavy metal poisoning, no. Syndrome scoria, no. Huntington scoria, no. The answer is clear cut, which is Wilson's disease. Had there been poisoning, there must have been history of ingestion of some or accidental ingestion of some heavy metal, है ना? But they have just given you the image along with a short history. Now, what are the other features that you are going to see in Wilson's disease? This is also your previous year question. So, serum copper. What will be the status of serum copper? I am going to give you three parameters. What will be the status of serum ceruloplasmin levels? What will be the status of urinary copper? In Wilson's disease, urinary copper is increased. In Wilson's disease, serum ceruloplasmin is decreased, but you will think that okay, urinary copper is increased probably because there is increased concentration of the copper in the blood which is getting filtered. So serum copper should also be increased. No, my dear friends, serum copper will also be decreased. Yes, the serum copper is carried with the help of ceruloplasmin, but since ceruloplasmin is decreased, serum copper will also be decreased. It is associated with a mutation on the chromosome 13, and there is a gene which is ATP7B gene. It is involved. Yes, so these are the few things that have been asked in the MCQ before. Yes, okay. Now coming over to our next disease, a young male complains of rhinorrhea, watery eyes and itching, goes towards allergic condition. Yes, the clinical image is provided. What is the diagnosis? So this is the image of conjunctiva. Now any insult to the conjunctiva can lead to two signs. One can be follicle, another can be papilla. Follicle is seen in infections, trachoma, bacterial conjunctivitis, viral conjunctivitis, while papillae, they are seen in allergic conditions. It can be giant papillary conjunctivitis, which is common in contact lens users, or there is big papillae which look like cobblestone appearance. This cobblestone papillae, they are seen in one disease, which is your VKC. VKC is vernal keratoconjunctivitis. It is an allergic condition, and it is also known as spring catarrh, although it is more common in summers, but the name is spring catarrh. It is more common in males who are teenagers. It is a bilateral condition. It is associated with type 1 and type 4 hypersensitivity reaction. If that is not in the option, go for type 1. If that is not in the option as well, go for type 4. So type 1 plus 4 hypersensitivity reaction, type 1 or type 4. Another important feature which you see in this condition is Shields ulcer. Shields ulcer. Then Maxwell-Lyon sign. Maxwell-Lyon sign is actually thick ropey discharge which has eosinophils. Then there can be pseudogerontoxin. It is the peripheral corneal opacity. Pseudogerontoxin. And what will be the drug of choice in this condition? It will be antihistaminics, and olopatadine is one that drug. Olopatadine is your drug of choice. So by this we have revised the entire vernal keratoconjunctivitis. So the answer is vernal keratoconjunctivitis. So if you can appreciate that these are papillae, of course not the conjunctivitis, because in conjunctivitis you are going to see what? You are going to see follicles, isn't it? And of course trachoma, you are going to see follicles. And vernal keratoconjunctivitis, yes, and angular conjunctivitis, again you are going to see follicles. In your angular conjunctivitis, it is caused by Moraxella axenfeld. Moraxella, you must have read about this organism in your microbiology. So it causes the inflammation of the angles of the eye. Yes, and the typical history of rhinorrhea, watery eyes and itching, it does not go well with bacterial conjunctivitis because it is an infection. It will lead to purulent discharge. Trachoma will lead again to purulent or mucopurulent. Angular conjunctivitis, purulent. Here they are typically saying watery eyes and itching is there. Yes, so this is how you connect the dots. All right, moving on to the next question. A patient with a vision of 3/60 to 1/60. Yes, so that means the vision is between 3/60 to 1/60. What do you understand by 3/60? 3/60 is that the patient is reading the topmost letter on the Snellen's chart from a distance of 3 meters, which a normal person can read from a distance of 60 meters. Numerator tells you where the patient is standing. Denominator tells you where the normal person can read from. So 3/60 to 1/60. In the better eye, which type of blindness is it? Now this is also your FMG PYQ. So there's a criteria. As per the criteria, if the vision of the patient is 6/18 to 6/60, that goes in the criteria of low vision. If the vision is 6/60 to 3/60, it goes in the criteria of economic blindness. And if it is 3/60 to 1/60, it goes in favor of social blindness. And if it is less than 1/60, then it goes in favor of manifest blindness. If the patient cannot perceive the light, अगर पेशेंट बोले ना मुझे दिन का पता लग रहा है ना मुझे रात का पता लग रहा है, so it will be PL negative. So it will be absolute blindness. So that is the criteria. ठीक है जी. Now I want to emphasize one very important change which has recently happened. What is the definition of blindness under NPCB and what is the definition of blindness under WHO? So earlier both these had two different definitions. As per WHO, the visual acuity in the better eye with best possible correction should be more than 3/60, or visual field should be more than 10 degree. Or in other words, blindness is defined as the visual acuity which is less than 3/60, less than equal to 3/60, and visual field less than equal to 10 degrees with best possible correction in the better eye. This is under WHO. So previously with NPCB, the definition was visual acuity less than equal to 3/60, visual field less than equal to 10 degrees in the better eye with available correction. That means you just ask the patient to read the letters on the Snellen's chart, just like that. But now NPCB has also changed its definition as per the grounds of WHO. Now it is with best possible correction. Like if I am wearing spectacles, without spectacle, let's say this is my better eye. Let's say this is my better eye without spectacles. It is 2/60. So as per NPCB previously, you will regard it as blind as per definition. But if I wear spectacles and my vision becomes 6/60, then as per NPCB, it will not be regarded as blind. But now both NPCB and WHO, if your vision is improving more than 3/60 with best possible correction, you will not be regarded as blind. Is it understandable? This is a recent change which has happened just 3-4 months back. So it can be asked, right? So what will be the answer to this question? So it is 3/60 to 1/60. So basically we are talking of this blindness and this is your social blindness. Now a patient presented with history of something getting in his eye while working in his fields. Fields means organic matter injury, है ना? Organic matter. Now the patient is having photophobia. Photophobia is inability to withstand ambient light condition. Photophobia does not mean you'll take a torch with very high intensity light and put it in the patient's eye, and of course with that even the normal person is going to close the eyes. You will not say that the patient is having photophobia. Yes, okay. Watering is there, and the following clinical picture. What is the most probable diagnosis? Now look out for the important features. Can you appreciate the conjunctival congestion? Yes. Can you appreciate the lesions, the small lesions here and the big lesion here? Probably these are your satellite lesions. And can you also appreciate something white at the bottom of the anterior chamber? This is your hypopyon. So satellite lesions, hypopyon with main lesion, and the ulcer is kind of dry looking. It is a dry looking with a typical history of organic matter injury. So it goes in favor of what? It goes in favor of fungal keratitis. But Pseudomonas keratitis, if you are suspecting, there has to be some history of contact lens wear. Yes, HSV keratitis, it does not present like this. In HSV keratitis, on fluorescein staining, there will be dendrites, there can be geographical ulcer, there can be deciform keratitis. Acanthamoeba keratitis, there will be ring-shaped ulcer. So if this is your cornea, so there will be just a ring-shaped ulcer, and acanthamoeba keratitis is more common in patients who have a history of washing contact lenses with tap water, or they have a history of swimming in pond with the contact lenses on in the village, because that is the pond in the village is a good source of acanthamoeba, but no such history is given. It is just that some organic matter has entered into the eye, so it is clear cut, which is fungal keratitis. But I want to give you two important points. What will be the treatment of choice? If the fungus is branched, you will go on for netamycin. What will be the treatment of choice? If the fungus is unbranched, you will go for nystatin. The new generation antifungal, voriconazole. These are few important things that you should remember. There is another sign that you see in fungal keratitis, that is your Wesley's immune ring. Wesley's immune ring is actually at the junction of normal cornea and infective cornea due to antigen of the fungus and antibodies of the host. So there is a antigen antibody demarcation line between the normal cornea and the infective cornea that forms a line or a ring. If it is circular, of course it will not be even, but it will be, you know, kind of zigzag, not like this. So if this is because the ulcer in the fungal keratitis is having non-defined margins, so it, as the name suggests, you might feel that there will be a even ring. No, it is not like that. So Wesley's immune ring can be like this. Yes, okay. So this is antigen antibody reaction. Okay, now a 70-year-old female visits eye emergency with sudden pain, less loss of vision just 6 hours back. Oh my. The patient gives a history of sitting in a room and she felt as if the voltage has suddenly dropped down. By this time, you already know the diagnosis. But still, post that she was not able to see the object clearly. On fundus examination, the following is seen. What is this? This is a typical splash tomato appearance of the retina. And you can also see non-defined disc margins. You can also see that there is haziness at the macula, goes more in favor of macular edema. Of course, macular edema will be very well seen with FFA or OCT RNFL. But anyway, so this is a clear-cut case of your central retinal vein occlusion. But let's rule out the other options one by one. In CRAO, there will be pale and milky white retina. There can be cherry red spot which is seen, and there can be cattle tracking. And the patient will typically give a history of sitting in a room when there was sudden switching off of light. Here, there is a history of sitting in a room when the patient felt that the voltage has dropped down. There is a difference. Yes? Okay. If there is vitreous hemorrhage, you may have a picture of neovascularization on the retina, because the new vessels, they are leaky vessels. Then they are going to leak the blood into vitreous humor. Now here you can see there are no new vessels, just that the whole retina is stained with blood. And also in vitreous hemorrhage, it is common in your diabetic retinopathy, in which you can see dot blot hemorrhages, you can see exudates, and of course when the patient will come to you, when you will do fundus examination, here the history is very small. It is just 6 hours back. Only 6 hours. Yes. Okay. But if there has to be some vitreous hemorrhage, there must be long impending neovascularization, diabetic retinopathy. Then diabetic retinopathy. Yes, diabetic retinopathy. Again, you will see dot blot hemorrhages. You can see neovascularization. You can see exudates, hard exudates, soft exudates, but you don't see anything like that. So the answer is your CRVO only. Ptosis in Horner syndrome is due to, what is Horner syndrome? Horner syndrome is actually oculosympathetic paralysis. Now, what are the structures related to eye supplied by the sympathetic fibers? So first and foremost is your sweat glands on the face. So there will be anhydrosis of face. In Horner syndrome, I am jotting down the points of Horner syndrome. Anhydrosis of face. Then there will be ptosis. Then there will be miosis. Why miosis? Because mydriasis is dilatation of the pupil. Miosis is constriction of the pupil. Miosis is via third cranial nerve, which is due to oculomotor nerve, which is a parasympathetic pathway. While mydriasis is due to sympathetic fibers, which dilate the pupil by stimulating dilator pupillae. But when there is paralysis of sympathetic fibers, so of course the parasympathetic fibers will overpower, and as a result the pupil will constrict. You call it miosis. Fourth is your enophthalmos. Enophthalmos is sunken eye appearance. Now, anhydrosis of face, because the sweat glands on the face are supplied by sympathetic fibers. In Horner syndrome, there is damage to sympathetic fibers. You know, Horner's pathway, it starts from hypothalamus, goes till C8, T1, T2 of spinal cord. Then the fibers move ahead. They pass between the clavicle and the tip of the lung. They pass under the clavicle and on top of the upper lobe of lung, and they come to lie here, which is inferior cervical ganglion, from where they go to superior cervical ganglion. Then these fibers loop around internal carotid artery to enter into the middle cranial cavity. Then they move forward. Ultimately, they are going to supply the dilator pupillae. Now, what happens is there is also paralysis of one muscle which is there in the upper eyelid. You will say, sir, we know that muscle. Okay, then tell me, what is the name of that muscle? No, that is not the muscle you are thinking. You are thinking of levator palpebrae superioris. No, levator palpebrae superioris is supplied by third cranial nerve, which is oculomotor nerve, which is parasympathetic nerve. But here we are talking of a nerve which is sympathetic, which is damaged, and it is supplying another muscle which is present in the upper eyelid. And boys and girls, that muscle is your Muller's muscle. So, but mind you, Muller's muscle helps in keeping the eyelid open by just 2 millimeter. If there is Horner syndrome, the lid droop will be just 2 millimeter, because 2 millimeter is the total drooping of the eyelid, which is controlled by Muller's muscle. So it is due to paralysis of Muller's muscle, and there will be just 2 millimeter of the droop. Now you will say, sir, okay, what about enophthalmos? Now mind you, enophthalmos is not true enophthalmos. It is pseudo enophthalmos. Why? Because when there is drooping of the upper eyelid by just 2 millimeter, so it may appear as if eyeball has sunk in, when actually it hasn't. So it is pseudo enophthalmos. But mind you, there was one question which was asked in your recent FMG exam, that which of the following is not seen in Horner syndrome? So anhydrosis, ptosis, then miosis, then enophthalmos. So in that case, you are going to mark enophthalmos, because this is your pseudo enophthalmos. But if the options are enophthalmos, ptosis, anhydrosis and mydriasis, then you are going to go on for mydriasis, because that is exactly the opposite option. So in this case, you are going to mark Muller's muscle, and orbicularis oculi is supplied by 7th cranial nerve, not by sympathetic fibers. LPS is supplied by 3rd cranial nerve. Horner's muscle is entirely different. It has nothing to do with your Horner syndrome. That is one muscle which helps in, which when you blink, it helps in propulsion of the tears. That is different. Yes. Okay. Now coming over to commonest cause of intraorbital tumor in childhood. Now when we are in the country where when we go to buy some vegetables, we accept some hara dhania and hari mirchi free. So although this is a single liner question, but I am going to give you buy one get 3 free offer. How? First, let's mark this single liner question. Commonest cause of intraorbital tumor in childhood. Rhabdomyosarcoma is most common malignant intraorbital tumor of childhood. Now, if we are doing malignant, let's do most common benign intraorbital tumor of childhood. This is your dermoid cyst. If we are doing of childhood, let's talk about adulthood as well. Most common malignant intraorbital. Mind you, I am saying intraorbital. I am not saying intraocular. Intraocular means inside the eyeball. Intraorbital means between the eyeball and the orbit, or inside the orbit. Malignant, most common intraorbital tumor in adults is your metastasis in the orbit. Orbital metastasis. And which tumor most commonly goes into the orbit metastasis? It is non-Hodgkin's lymphoma. Okay. Now similarly, we have talked about malignant. Let's talk about benign now. So benign is capillary or cavernous hemangioma. It is the most common benign intraorbital tumor in adults. Capillary hemangioma, or you can even go on for cavernous hemangioma. Cavernous hemangioma. Yes. Buy one get 3 free. Okay. चलो एक क्वेश्चन और देते, तो आज मेरा मूड बहुत अच्छा है. Now retinoblastoma is most common malignant intraocular tumor of childhood. Not orbital, my dear friends. Intraocular tumor of childhood. एक और क्वेश्चन दे दूं? थोड़ा सा स्माइल करके बोलो. चलो एक और क्वेश्चन दे दिया. Choroidal melanoma is most common malignant again ocular tumor of adulthood. तो यहां पे I have given you 2 intraorbital tumors in childhood, 2 intraorbital tumors in adulthood, benign and malignant, and 2 malignant tumors of the eye in childhood and in adulthood. I'm sure you have understood this. Don't get confused. Whatever 6 points I have made you write, so they are very, very important. They have been asked multiple times in your previous year examination. Let that be FMG, let that be NEET, PG, INI-CT. Yes. Okay. Now identify the cranial nerve supplying the muscle marked as green. Now can you tell me which muscle is this? बता पाएंगे कौन सी मसल है? So this is a clear cut. The muscle is inferior oblique. But you know about the nerve supply of the extraocular muscles SO4, LR6, rest 3. That means that superior oblique is supplied by 4th cranial nerve. This is your superior oblique. This is your superior rectus. This is your inferior oblique. This is your inferior rectus. And this is your lateral rectus. So this is the medial point from where there is a pulley, trochlear pulley, from where the superior oblique is going to pass and getting attached just behind the equator. है ना? Just behind the equator. Okay. So lateral rectus is supplied by 6th cranial nerve, which is abducens nerve. Superior oblique 4th cranial nerve. which is trochlear nerve, and rest of the muscles are supplied by inferior oblique, superior rectus, inferior rectus, medial rectus. They are supplied by third cranial nerve, which is oculomotor nerve, and hence this answer is pretty straightforward. Now coming over to the 10th question. A patient has a history of cataract surgery 6 months back with progressive deterioration of the vision. Now you can see that this is the artificial IOL, this is the optic part of the IOL, and these are the two haptics. Yes, and what can you see just behind the optic? Can you appreciate the pearl like things, small dots, small dots? So boys and girls, these are your Elschnig pearls. Elschnig pearls, they are after cataract. The other name of after cataract is posterior capsular opacity, or PCO, posterior capsular opacity. So when you operate the patient, so suppose I have operated the patient, I have implanted the artificial IOL. Yes, so there are some E cells. What are these E cells? These are equatorial E cells. These are equatorial epithelial cells which lie at the equator. Yes, when you implant the artificial IOL, so they will crawl back, and they will start getting deposited between the posterior part of the optic and posterior capsule. Then they will start to proliferate. So in an uneventful cataract surgery, when the patient comes to you with the progressive loss of vision and you examine the eye and everything appears normal, so you should think of the most common late complication of cataract surgery, which is your after cataract. If there is pseudophakic keratopathy, there must be corneal edema. In pseudophakic keratopathy, so it leads to damage to the endothelium layer of the cornea, which can lead to corneal edema. PSC is posterior subcapsular cataract, when the cataract surgery has already taken place. So how come the posterior subcapsular cataract happens? It happens to be in the natural lens, na? So this is a very vague option. Subluxation of the lens. Why subluxation? The lens is at its place. There is no movement of the lens. Yes. So there is A, which is the answer, posterior capsular opacity. What is the treatment of posterior capsular opacity? You take a laser, which is Nd:YAG laser, and you rupture the posterior capsule. The wavelength of Nd:YAG laser is 1064 nanometer. All right. So this was about a short discussion, but as I always say to all of you, it is important to have a clinical orientation of whatever we are doing. I believe you are not going to appear for only one part of your exam, which is ophthalmology, but you are going to prepare all the 19 subjects. So in that scenario, it becomes kind of difficult to be able to recall all the important points. So what I do is I show my real patient videos in the class so that you are able to connect the dots. I still remember when I was appearing for my PG entrance exam and I came across some difficult questions. All I could remember was during my clinicals. Okay, I saw that patient, so I palpated the spleen, I palpated the liver, I actually auscultated the patient. So these are some real audio visual inputs that are stored in your brain forever. So that, keeping that idea, so now I am going to show you the 3 cases. The questions we have already discussed, but the 3 cases. So first case is that of my fungal corneal ulcer. So you will see that the patient is typically giving a history. I am asking the patient kya hua tha, and he is saying aankh mein katta mitti pad gayi thi. Katta mitti is the organic matter injury, typical. And in fungal keratitis, the signs are more than symptoms. By seeing the eye, you may feel that the patient will be in intense pain. But no, the patient is relatively comfortable. That means the signs which you are seeing, that is more than symptoms.
घटा पै गया जी।
कितने समय पहले?
40 दिन पहले।
चेक आउट। अच्छा, क्या काम कर रहे थे तब आप?
थोड़ा मिट्टी वाला काम कर रहे थे।
मिट्टी वाला काम। अच्छा, तो उसके बाद क्या हुआ? आंख चिट्टी पड़ गई? He is a farmer
नहीं जी, दर्द
by occupation। अच्छा,
उस तो बाद फिर मैं इलाज करवांदा रहा उथों जिथों बनवाई सी।
अच्छा,
ते वो इलाज जेड़ा भी वो नहीं हो सकिया।
ठीक है,
सानू इत्थे आना पै गया।
अच्छा, हाँ जी। तो अभी दवा वगैरह डाल रहे हो आंख में? Are you able to appreciate?
दवा वगैरह दवा दारू डाल रहे
हाँ
हो?
हाँ
Daru is the Punjabi word
चल रहा है।
for alcohol.
ठीक है जी,
No,
ठीक है।
not for alcohol. Sorry, Daru is the Punjabi word for eye drops. Don't take it otherwise. I still remember. So when I joined my PG, so I watched my consultants asking the patient के आपकी दारू की बोतल है, दारू की बोतल खत्म तो नहीं होगी है, उसी से आराम आएगा. I was like, भाई प्रॉब्लम आंख की है, हाउ कम दारू इज रिलेटेड टू द ट्रीटमेंट ऑफ आई. मैं कहा भाई ये तो नई डिस्कवरी है, ऐसा तो मैंने आज तक कभी सुना ही नहीं था, ना मैंने पढ़ा था, ना मुझे कभी किसी ने पढ़ाया. तो दारू इज एक्चुअली पंजाबी वर्ड फॉर आई ड्रॉप्स. डोंट टेक इट अदरवाइज. All right, so that was your fungal corneal ulcer. Now I showed you the first patient. First, we discussed the first case now, in which there was an X-ray. There was orbital floor fracture. So this is, you can see this bone. This is butterfly shaped bone. This is your sella turcica, where there is pituitary gland, and butterfly shaped bone. So there is the central body of sphenoid, and there are two wings, the lesser wing and greater wing of sphenoid. And I am going to show you the front view. Now you can see the front view. The yellow bone which you see is maxilla, and the lilac bone which you see is actually zygomatic bone. So the bones which are forming the base of the orbit is your palatine, which is not visible here, the maxilla and the zygomatic. But the bones which are forming the lateral wall of the orbit are zygomatic and greater wing of sphenoid. The bones which are forming the roof of the orbit is blue bone, which is your frontal bone, and it is your lesser wing of sphenoid. Then the bones which are forming the medial wall of the orbit, they are maxilla, then it is lacrimal, it is ethmoid, and it is body of sphenoid. Now can you answer me? This is your what? So you need to see the video. Once you are done seeing this video, you need to give me the answer of the boundaries of this structure and what is the name of this structure. I'll be looking forward to your answers, and I'm going to share my contact number, the WhatsApp number, in the end. So you need to first tell me the name of this structure and the boundaries of this structure. This is your NEET PG 2020 question, right? Okay. So you can see this. All right. Now I am going to show you the third video, which is that of posterior capsulotomy. So posterior capsulotomy, how it is done? So the lens is implanted, but of course there are equatorial epithelial cells which are going to get collected between the posterior part of the IOL, which is optic, and the posterior capsule. Then you rupture the posterior capsule. So this is the machine by which you do Nd:YAG laser. So there's a slit lamp on which Nd:YAG is installed, and you ask the patient to rest his chin on the chin rest. Then you focus the light on the posterior capsule. Can you see this whitish plaque which you can see? Whitish plaque, are you able to appreciate? So I am trying to focus the two red dots on that whitish plaque. That is actually posterior capsule, which has become hazy due to collection of equatorial epithelial cells. So this is the slit lamp. You have asked the patient to rest his chin on the slit lamp, and you can check out my index finger on the joystick. And the moment I am going to fire a laser, you will hear a sound tick tick. That will tell me that the laser is firing. Alright, now I am going to show you how it is going to rupture the posterior capsule. Now could you appreciate that? So I am actually focusing on the posterior capsule, and then I am going to rupture this now. So this is how you rupture, but you have to take care. Don't keep on rupturing so that you go till the far periphery. Otherwise the lens which is there in the capsular bag, it will fall back in the vitreous cavity. It can get subluxated, it can even get dislocated. So you have to be very, very aware, and you have to be very, very cautious that you just have to do capsulotomy only in the central part of the capsule. You are not supposed to go till the far periphery. Is it understandable? So this is your posterior capsulotomy, which is your treatment of choice. Right now I am going to share my contact number. You need to give me the answer of the question which I have asked, so I'll be waiting for your answers. So you can WhatsApp me and I'll be happy to correct you in case there is any error on your side, in case you could not tell me properly what is the name of that structure and what are the boundaries of that structure. Right, I hope you enjoyed the video, and yes, I'll be coming up with more such informative videos. Best wishes and take care.